No disclosures on this one either. So these are learning objectives for this talk. So we'll talk a bit about the importance of staging and soft tissue handling in tibial, I'm going to have plateau in my brain, in pilon fractures. We're going to talk about the importance of careful planning. We'll talk about a key learning point is that it's your reduction strategy, not your fixation strategy, that dictates the choice of approach. And then we'll talk through each approach a little bit. So here's just a case example. It's a 28-year-old who's in a motorcycle crash. He's got this highly comminuted tibial pilon fracture. It's actually an open lateral wound in this case. So how can we tackle a complex situation like this? And the first key principle is we have to respect the soft tissues. I mean, we were just talking about this again on plateaus, but these patients, even if they're not open, they often have severe soft tissue injuries, blistering. This is not an ankle that you want to acutely be putting multiple incisions on to try to get a reduction in fixation. So, and this is the case, I would say, for the vast majority of these high-energy tibial plafond fractures. So stage one of treatment is an external fixator. The goal here is not an anatomic reduction. We're looking for functional reduction, length rotation alignment, basically just trying to get the talus centered on the tibia on both views. That's really your primary goal. That's going to splint the soft tissues, allow the swelling to come down, and give you a much safer situation to go in and do your definitive fixation at a later date. So coming back to our case, the way I typically do this, I put a pin in the tibia, approximately a transfixion pin in the calcaneus, and then set up a delta frame. That's going to allow you to at least get your coronal alignment close and also get your length restored. You can kind of, depending, in this case, it's a varus fracture, so a little more pull on the medial side is going to help us get that straightened out and get things in a much better aligned situation. I then usually will add a second pin in the tibia and also add a pin in the midfoot to help control dorsiflexion and plantar flexion. So this is kind of what it looks like. And your goal here, like the goal at the end of the case, you can't really tell much from the distal tibia because it's all in pieces. But what you really want to do is make sure if you draw a line down the tibia that you're in the center of the talus on both views. And on the lateral image, a good reference point is the lateral process of talus. So you really want that line going right through your lateral process. So that's going to make sure that you've got the alignment of in a reasonable approximation. You see here, I'm just circling the cuneiform pin there. That's just to help maintain the dorsiflexion and plantar flexion of the foot. This is kind of what it looks like clinically. So 2 pins in the tibia, pin in the calc, and pin in the midfoot. One of the big controversies is should you fix the fibula when you're doing a pilon fracture? And I think there are definitely some benefits to it, but only if you will be the one who's going to do the definitive fixation. If you're going to be, doing the X-fix and then passing it to a partner, or you're going to transfer it to another place, just stay away. Just focus on that functional reduction with your X-fix and don't put any incisions on the patient because people have different philosophies on there, and it may affect the subsequent approaches that are going to be done. The second thing, so if you are going to be the one doing it and you're going to go after the fibula, is you need to get it anatomic. If it's a really comminuted fibular fracture and you can't get it anatomic, you're actually going to make your life harder when you go to do the tibia side. So it needs to be typically either a simple fracture or maybe there's one butterfly or something so that you can make sure that you get that fracture anatomic. And these are not like the quick clicker, Weber B fibula where you can do it in 20 minutes. These you got to be prepared to sit for an hour or sometimes even 2 hours to get the fibula right, because if you don't, you're only making your life more difficult. You have to get it anatomic. In terms of approach, I would strongly recommend if you're going to do it at the initial setting, use a posterior lateral approach. The posterior lateral approach is more soft tissue friendly because it's not directly over the fibula, and it doesn't box out your future approaches. You can still do an anterolateral if you need to. You can still use that same approach to get to the back of the tibia if you need to. So it's going to preserve your options for the future. What's the benefit of it? Well, a big thing is length. So this is a really great example. This is a highly comminuted tibia fracture. It's really hard to judge what the length is, and the fibula is, you can get a sense it's maybe close, but it's hard. It may be over distracted. Once you fix it, it becomes much more clear like what the anatomic length ought to be. It also just gives you a much more stable construct while you're waiting for the soft tissues to heal when you fix the fibula. And it's one less thing you have to do at the definitive surgery, so that's also an added benefit. So this is kind of the mantra: span, scan, and plan. And it really ideally goes in that order. So spanning with an X-fix, scanning with a CT, and then coming up with a preoperative plan. It's important that the CT scan come after for a few reasons. One is just the quality of the image is generally better if it's aligned. But for me, actually, probably the more important thing is that if sometimes with ligamentotaxis, those fragments actually will reduce a fair amount compared to the pre-injury situation, and that may have a big impact on your approach selection. For example, if the posterior lateral fragment is really maybe very far off on your initial injury CT scan, but a post-X-fix CT scan, it may actually reduce with ligamentotaxis, and suddenly you don't need that posterior approach anymore. So really important to wait and get the CT scan after the X-fix is done and make a good plan. These are kind of the workhorse approaches. So you've got a couple anterior options, anteromedial, anterolateral, and a couple posterior options. So we'll go through each of these a little bit. The anteromedial approach generally goes medial to the anterior tibial tendon. You're moving the whole anterior compartment to the lateral side. This is kind of what's often described as the extensile version, so it actually curves a little bit medially at the level of the ankle joint, which allows you to get further around the medial side of the tibia. This is kind of what it looks like when it's opened up, so you can see you get good access to the joint, you have good access to the front and the medial aspect of the tibia. You can even reach around to the posterior medial fracture line, depending on how far you carry that incision. So it's a very extensile exposure. You can extend it proximally as far as you want, and you get a lot of access. And it's pretty straightforward. There's no nerves that you need to deal with, provided you elevate that whole anterior compartment subperiosteally. The downside really is the wound healing issues with this. It's a pretty high risk approach. And if you have a really fracture sedging very laterally, a small Chaput fragment, you can see you don't have great access over to that lateral side of the ankle joint. This is what you're worried about is this necrosis of the corner of the flap. The key thing here when you do the approach is don't expose the anterior tibial tendon. Keep it within its sheath. As long as it stays within its sheath, you can ride this out. So this patient just got local wound care. Eventually that sloughs, and you can just kind of either do local wound care or worst case a skin graft if it's bigger. But it's not catastrophic. But if you have tendon exposed, then all of a sudden you're dealing with flaps, and it's a whole different situation. So keep the tendons inside the sheath. If you accidentally get inside, just repair it in the moment. And you can then ride out these wound healing issues when they occur. Anterolateral approach, so here you're going to be going on the lateral side of the anterior compartment and sweeping it medially. It's a more limited approach because the anterior compartment crosses it, so you can't just keep extending it proximally. But it is a little more soft tissue friendly because of that. It's a straight line incision, it's smaller. It gives really great access to the lateral part of the joint for a smaller Chaput fragment. But I think it's technically more difficult because you just don't have such an extensile exposure. You can't go proximally as far because of the crossing anterior compartment. The superficial perineal nerve is in the superficial dissection, so you have to be careful with that, identify it, and treat it nicely throughout the case. But the downside really is you don't have that access to the medial side. So it often, although it's more soft tissue friendly maybe, it often requires additional approaches. So that may negate some of the soft tissue benefits if you're doing a whole second approach. Posterior lateral is shown here. I already talked about this for the fibula, but it's a great approach for the tibia as well. You can work on the front or in front of the perineals or behind the perineals if you want to go to the tibia. So this is kind of what that looks like. If you retract the perineals back, you're looking at the fibula. You retract them anterior, you get to the tibia. So it's a nice approach and versatile. This is more what it looks like on a live clinical patient. You can just see you can get to both sides depending on what you need to do. The posterior medial approach comes in a lot of different flavors, and I sort of think of it as like an extensile posterior medial or a more limited posterior medial. I don't really like this, which is the more extensile posterior medial approach, although it is very powerful. You can work on either side of the neurovascular bundle. If you're on the posterior side of it, you can be doing a lot of work on the back of the tibia. If you're on the front of it, you can be working on the medial side of the tibia. So it really gives you quite a bit of power to do that, but you can see it's a pretty big soft tissue insult. So often I'll do it more as a more limited posterior medial approach combined with the anterolateral in order to get access to that posterior medial fracture line. So this can be a nice option. You're really just retracting the posterior tib back and reaching around to get access to that posterior fracture line. So my algorithm for approach, generally I talked about the fibula, always posterior lateral for the reasons we talked about. And then for the other approaches, it depends. So for B-type pilon fractures, it's pretty straightforward. So B-type is partial articular. You just go where the fracture is. If it's an anterior B-type, go to the front. Posterior B-type, go to the back. If it's a C-type fracture or complete articular fracture, it's a little more complicated. Almost always, though, you're choosing between one of the anterior approaches, and then you have to make a decision about whether you need that posterior approach to get the posterior tibia reduced. So just to emphasize the B versus the C type, so a B type is when some part of the joint is still in continuity with the shaft. So this is a posterior B type fracture, so it's just a large posterior malleolus fracture. That's going to get a posterior approach and posterior buttress plating. On the right is our case from the beginning. That's a C type fracture, and that one's going to need more work. So for the C types, how do you choose between anteromedial or anterolateral? The superficial thing that everyone talks about is just where does the anterior fracture line exit? If it exits more medial, go anteromedial. If it goes more lateral, go anterolateral. That's a good starting point, but there are other factors that may come into it. If you feel like you really need a posterior medial approach, that's not going to be compatible with the anteromedial. So if you feel like you really need a posterior medial, you kind of have to do anterolateral. So that's something you have to kind of think through. Posterior medial versus posterior lateral is interesting. We often talk about reducing the posterior fragment, but you have to ask yourself, reducing to what? So sometimes you're reducing the posterior fragment to the shaft. Sometimes you need to reduce the posterior fragment to the medial fragment. For that, a posterior medial is much more effective than the posterior lateral. And like this case example, you look at the back of that tibia, trying to do a posterior lateral and reducing that posterior fragment to the shaft is not going to be a lot of fun. But reducing that posterior fragment to the medial fragment actually is very doable, and that's a good case for a posterior medial approach, in which case you're kind of obligated to the anterolateral in the front. And then there may just be so this is just an example of that case, so the anterolateral getting the front, and then the posterior medial getting that posterior fracture line. And then the last is just soft tissue considerations. You don't really want to do an anteromedial through like an open fracture wound, so that also comes into play. Once you've got your reduction, then you do your definitive fixation. Your goal is going to be to secure the articular block to the shaft, usually with one of these large anterolateral plates, and then some form of medial buttress. You can modulate the size of that buttress plate based on how accommodated the metaphysis is. So this is like this one's not at a very high risk, so it's just a third tubular plate. Other cases, you might need a very large, stout medial plate. But I think the key point is that it's not based on the approach. So you can do an anterolateral approach and put the anterolateral plate in and then put in your medial plate through a little mini open medial approach, or you can do an anteromedial approach and put both plates in the same way. So the message is that you choose your approach based on the reduction, not based on the fixation, because the fixation can go in either way. Soft tissue management, I can't emphasize it enough. You can see there's a horrible soft tissue envelope. You want to be really meticulous in getting a good, deep fascial closure. I usually throw all the sutures and then tie them sequentially in order to make sure I get those tied. And then Allgauer Donati sutures, which are the best for the flap, to prevent flap necrosis for the skin. So take-home messages, stage treatment and good soft tissue handling are really critical to avoid infection, wound healing problems, and tibial pilon fractures. Remember, the posterior lateral approach, I think, should be the workhorse for fibulas in the setting of a pilon. B-type fractures, just go to the apex and buttress. C-type fractures, you're going to do one of the anterior approaches and then decide on your posterior approach based on the posterior lateral fragment. Thanks.